My name is Shefali Patel, and I am a fourth-year medical student at the Florida State University College of Medicine. The title of this research project is Nitazoxanide as Salvage Treatment for Refractory Helicobacter pylori Infections. I collaborated with Dr. Jose A. Giron, an infectious disease specialist in the Orlando area. Helicobacter pylori is a gram-negative microaerophilic bacterium associated with peptic ulcer disease, gastritis, gastric adenocarcinoma, and gastric-associated lymphoid tissue carcinoma. Per the American College of Gastroenterologists, standard therapy for an H. pylori infection is a proton pump inhibitor, clarithromycin, and either amoxicillin or metronidazole. Unfortunately, resistant rates to standard regimens have increased dramatically throughout the world, with rates up to 15% or higher for metronidazole and clarithromycin in many areas. Thus, a salvage treatment is needed for refractory infections. Nitazoxanide, an anti-protozoal agent currently approved by the FDA for cryptosporidium and giardia infections, has shown promise in several international studies. This takes us to the objectives of the study, which were 1, to determine the overall efficacy of nitazoxanide in treating refractory H. pylori infections, and 2, to propose a possible nitazoxanide-containing regimen for treating such infections. Data was collected via chart reviews from an infectious disease practice with patient encounters occurring between 2015 and 2021. To qualify for the study, patients had to meet the following criteria. They had to have proven symptomatic H. pylori gastritis or ulcer via a stool antigen test or gastric biopsy, and failure of at least one course of treatment with a standard regimen. The sample size totaled 28 patients with 33 treatment episodes utilizing 10 different nitazoxanide-containing regimens. We defined a successful treatment episode as one with a negative stool antigen test performed at least 4 weeks post-treatment. In Figure 1, we have listed a breakdown of all utilized salvage treatment regimens. Each regimen contains nitazoxanide plus a combination of 1 to 2 antibiotics, proton pump inhibitors, and bismuth subsalicylate. The range and length of salvage treatments was 4 to 12 days. Overall, the eradication rate for nitazoxanide-containing treatment regimens was 72.7%. with 79.2% of the successful treatments resulting in complete symptom resolution. The most commonly reported residual symptom was abdominal pain. 4 patients reported potential adverse effects during treatment, and these included bloating, diarrhea, and nausea. A breakdown of outcomes per treatment regimen is shown in Figure 2, and remarkably, Treatment F showed a 93% success rate. Treatment F consisted of rifabutin 150 mg twice per day, nitazoxanide 500 mg twice per day, omeprazole 20 mg twice per day, and 1 tablespoon or 15 cc's of bismuth subsalicylate 3 times per day. Based on our findings, nitazoxanide may be used to successfully treat refractory H. pylori infections. We recommend a treatment regimen of nitazoxanide 500 mg twice per day, rifabutin 150 mg twice per day, omeprazole 20 mg twice per day, and 1 tablespoon or 15 cc of bismuth subsalicylate 3 times per day for 8 to 10 days. Prior to concluding this presentation, I would like to address a few limitations of the study, namely our small sample size of 28, which does increase the probability of statistical errors. We are continuing the study and we are continuing to add more patients to our sample size. Additionally, we did not have the ability to test antibiotic susceptibilities, as gastroscopy was not repeated for any patient in this study. However, overall, the main advantage of our proposed treatment regimen is shortened treatment time of 8 to 10 days. Other studies have achieved cures with treatments lasting 14 days. Shorter treatment regimens are more advantageous because they decrease overall antibiotic exposure, lessen the risk of adverse effects, and reduce the risk of producing resistant organisms. We believe that further evaluation of nitazoxanide-containing treatment regimens is warranted, especially the nitazoxanide rifabutin regimen in comparison to currently recommended standard salvage regimens. I'd like to thank Dr. Jose A. Giron and the staff at Sunshine Specialty Healthcare in Orlando, Florida for their guidance and assistance on this endeavor. Additionally, I'd like to thank the Florida State University College of Medicine for the opportunity to conduct this research and for the opportunity to represent the program with this presentation. Thank you all for listening today.